All right. Hi, everyone. It's really great to see you here today. My name is Erin, and I'm one of the faculty members for our community of practice in East Africa, looking at ways to incorporate palliative care into the humanitarian response in our region. And I'm one of the executive members with PallCHASE, and also really excited to be part of the faculty leading this community of practice. We're really excited today. We have a new speaker with us and are really excited also to hear the case that's going to be shared from Kenya. Just a few housekeeping things. If you are able to rename yourself, I think mostly everyone is, but just introduce yourself through the Zoom. At the very top corner, there's kind of the three dots. You can put rename yourself if it comes up as a different name. And then it would be great to introduce yourself in the chat. It's always great for our speakers and other people on our call to know who you are. So if you wanted to put in the chat your name, where you're working, and yeah, what your role is within your organization, that it helps us get to know one another. We have a few other faculty members on the call with us. So I'd like to say hi to Sarah and Vilma. They have been very committed to the group. And they're always available, of course, to connect with you between our sessions. So we are a community of practice. We meet once a month on Tuesdays at 3 p.m. East Africa time. And we currently are using our IECHO platform to register for this community of practice. So you just need to have an IECHO account, and then you can join us free of cost. We occasionally run certificate courses, and we are connected with PallCHASE, which is a network of humanitarian and palliative care providers that are looking at ways to really increase access to palliative care in these settings. And I do see a lot of familiar faces on names on the call today, so it's really great to have you with us. We have people calling in from Kenya, South Sudan, and Rwanda I see here as well. So it's great to have you all. I'd like to take a minute just to introduce our speaker. We have a new speaker with us. She's a palliative care physician currently based in the US in San Francisco. And she came on board as a recommendation from one of our longer-term faculty members, Dr. Jesse. Some of you might have been familiar with. But we're really excited to have Dr. Matinrad with us today. And she's going to be teaching us about grief, loss, and bereavement in humanitarian settings. So I'll let her give a bit of an introduction to herself, as she's new to our group. Yeah, over to you. And thank you for joining us today.
Thank you so much. I'm so glad to join y'all all the way across the world and across time zones. So I'm Hedieh. I'm a palliative care physician, as you said, Erin, and I am originally from Iran, and I moved to the US as a child, and I currently practice in the hospital as an inpatient palliative care doctor, and I also teach our palliative care fellows. And one of my goals is just creating community and having palliative care communities across the world and learning from each other, including folks back home in my home country of Iran, who are developing palliative care there. So yeah, that's my introduction. And I have an 8-month-old baby who is cooperating right now and being asleep at 5 a.m. Instead of wreaking havoc. So I am going to share my slides, and I will also say, I think I have some experience working in humanitarian settings, and I think folks on this call are much more experienced in that than I am. And so I'll humbly say that my presentation, if there's any parts of it that don't apply to you, or yeah, are incomplete, please forgive me for that. And I'm looking forward to for us to all learn from each other as well. I'm going to share my slides now, and feel free to interrupt me at any time during the presentation as well. Sorry about that. My Zoom just quit randomly.
Oh dear.
Here.
You need me to share your screen? Is that easier?
It may be. I don't know why my Zoom. Yeah, that would be great, Erin.
Okay.
Thank you.
Yep. Sorry.
No worries. Actually, if you, I wonder if it says host disabled participant screen sharing.
Sorry about this, everyone. We're almost ready.
Let me see if I'm able to do it now.
Mine is also good. Sorry, I just had to
No,
download it.
no, all good. Let me see if this works now. Should be able to see my
Yeah,
slides.
perfect.
Oh,
Yep.
yeah, okay, great.
Okay,
Sorry about that.
here we
Here
go.
we go. All right, so we're going to talk about grief, bereavement, and loss in humanitarian settings. And oops, here we go. And so our learning objectives together today is that by the end of our 20 minutes together, you should be able to define what grief, bereavement, and loss are, explain the different types of grief in palliative care settings, appreciate the heterogeneity, the differences of the grief experience, and how culture and religious beliefs may shape it, and to be kind of able to support a grieving person with empathetic presence, with listening at an introductory level, or wherever kind of your comfort level is. So what is grief? What is bereavement? What is loss? I find that sometimes poetry and art explain things better than definitions. And these are two poems that encompass grief that I really like. And one is, to live in this world, you must be able to do three things: to love what is mortal, to hold it against your bones, knowing your own life depends on it, and when the time comes, to let it go and to let it go. And another poem is, someone I loved once gave me a box full of darkness. It took me years to understand that this too was a gift. I think in art and poetry, people try to define what this feeling of grief that can feel like a hole in one's heart, the whole world kind of shaking, what that all feels like. And I think we can define it, but ultimately, until you experience it, I think it's hard to completely understand. And I think as a starting point, just knowing that and knowing that our patients and people that we're caring for are experiencing something that we may not understand. And we can just acknowledge that from the get-go in our conversations with them. But maybe more of traditional definition. So grief, it is a normal response to loss. So it's something that we expect any of us to experience when we're experiencing a loss. And loss doesn't necessarily have to be, death of a loved one, or it could be loss of identity. I used to be able to take care of my own household and cook for my family, and now I can't because of my serious illness. And I'm experiencing loss of identity as a caretaker of my household. It could be loss of limb that as a result of, this conflict, this war that I'm living through. I now have lost a limb and I'm no longer able to do some of the activities I did before, or just losing the identity of a person that is completely able-bodied. I can grieve. A person can grieve any of those things. Grief is not specific to death and dying. And it's an emotional process. It's an emotional response to loss, but it also can include, cognitive and behavioral ways that, you're experiencing your loss. So, it does not just include, I'm feeling sad, I'm feeling lonely, I'm missing I'm missing this identity, I'm missing my loved one who has died, but it also includes behaviors. And for some people, they may not actually express themselves much emotionally, but it may be that now suddenly they are not talking to anybody, or they are isolating themselves from their friends or family. And you ask them, how are you doing? They may say, I'm fine, but their behavior is showing that they are grieving, and that's how their grief is showing up. So really appreciating that grief for different people looks very different. And bereavement, it's grief of loved ones following a death. It's more specific to grieving, after the death of a loved one. And it may also be used to describe the duration of time one is grieving as well. So the period of bereavement. Many of us may be familiar with this framework of grief as the 5 stages of grief: denial, anger, bargaining, depression, and acceptance. That was developed by Elizabeth Kubler-Ross. And she, as one of the mothers of palliative care, at least, was seeing this in how her patients at the end of life were experiencing their death, their imminent death. And I think this is a framework that is helpful, and also it's not a linear process of, this is the one direction that it goes. It's not a linear process. It can be kind of all over the place, moving between, depression into anger, into denial, and all across the board. And so this and the probably the main feature of grief, though, is that the strength of emotion should lessen with time. So it can come in waves of, something is reminding a person of their loved one who's passed away, and suddenly there are periods of high intense emotion of sadness or anger about the loss. And then over time, these waves become less intense and less frequent. And that's how, there's a period of acute grief, and then the grief doesn't go away, but it just changes, and it becomes less intense, and a person would be able to continue living their day-to-day life. Whereas at the beginning, it may be hard. And that's why in many cultures, there's mourning periods. So going into our patient narrative, 50-year-old woman who's diagnosed with metastatic ovarian cancer is admitted to the hospital with a small bowel obstruction, and the prognosis is shared to be likely on the order of weeks. Her 25-year-old daughter has just found out she's pregnant, and she's crying at mom's bedside. When I just want us all to take a moment and think about like what is the grief that that the daughter may be experiencing and how we would define that. Um, and then I'm happy to share with you all. So this may be what we call anticipatory grief. So, you know, after finding out bad news that time may be shorter than you expect, a person or their family, their loved ones may start to grieve losses that are going to happen in the future. So the loss hasn't happened yet, right? The daughter who's pregnant, her mom is still with her in that moment, but she's grieving the anticipation of losing her mom before her mom may be able to see this baby. Anticipatory grief is something that it's so important that we identify because it is affecting the state that somebody is in. So if a person is, the patient that we were talking about, a 50-year-old lady with metastatic ovarian cancer, she can also have anticipatory grief of reviewing her life and saying, I never got to see my grandchild. I never got to do, this that was so important to me, and start to grieve in anticipation of what they're going to miss. Sometimes anticipatory grief is so intense that a person is not able to move beyond in order to make decisions or interact with the healthcare setting, with doctors and nurses. And that's when, it's important that somebody who is a mental health provider or a chaplain is able to intervene and kind of name that, like, this is, you're grieving already. You're grieving a loss that you anticipate. And sometimes just by naming it and by acknowledging it, a person is able to process it. And, the other thing is anticipatory grief can sometimes take away from the moments that do still exist. So in the case we were talking about, this daughter still has her mom with her. There's still time. That time is short, but how can they actually, what is most important about the time they still have together that they can use? How can we help them, help her see that, and process her anticipatory grief, that it's true that mom may not be there for baby, but is there another way to make meaning? Is there a way that, mom can write letters to her unborn grandchild? And that way that can be part of processing this anticipatory grief of future loss. And then going into kind of what is normal grief, quote unquote. And again, it can look different for different people. But grief normally is essentially grief that happens intensely after a loss, and then the intensity of it can lessen or should lessen over time so that a person is able to live their life after some acceptable period of time of intense bereavement. That period of time is very culturally relevant. And so, you know, there's the DSM, the various psychiatric guidelines. Some express that like up to 6 months of grief and bereavement that may limit one's functioning in life is considered normal, and others say like a year. And in some cultures, in some settings, less time or more time may be appropriate. And so I think my main point here is that normal grief can just look very different, and in the context of culture and religious and mourning, and these things are, and social political elements are really relevant. And grief can also look like activities and rituals that somebody's doing. So the color of clothing to wear to indicate that you're grieving. In some cultures may be Black, and in another culture may be white. Or in some cultures, you know, showing that you're grieving is an important part of honoring the person who's passed away, specifically talking about grieving death of a loved one. And also indicating to other people that you're grieving so that they can be there for you, so that your community can support you through your grief. So for example, in some cultures, not shaving for a man may signal to others that they're grieving. And you know, I really like this photo because I think, again, going back to art and poetry, and sometimes they explain things better, is that sometimes grief can just feel like a hole, and that hole may not fill over time, but instead you build out your life further around that hole. And that's how grief doesn't necessarily go away. We talked about grief for, you know, a defined amount of time. For some people, their grief may become persist longer and become disruptive to the functioning of their life. So it goes by different names, or it's been defined by different names, but one is complicated grief or prolonged grief disorder. And in different studies, about 7 to 20% of bereaved people can experience a persistent or prolonged period of intense loss. And that duration of how long that is defined differently. Some say 6 months, some say 12 months. But basically, it's when the symptoms of grief, of, you know, sadness, missing the loss, the you know, longing for the loved one, persist over a long time, and the person is really preoccupied with the loss, and intense longing for the deceased person, and having really intense emotional pain. And as a result, having considerable difficulty with just their day-to-day functioning, their, you know, their work, or being, you know, a present member of their family. And so this can be very debilitating. And also, it's been shown to increase the risk for both negative mental and physical health conditions. So this would be something that, you know, our role, you know, my role as a palliative care physician, or any of us in our different settings, would be to try to identify it, and would need help from a mental health professional. So it's gone beyond the normal grieving time. Some risk factors for it that have been identified is some, you know, childhood abuse and neglect, low social support, low preparation for the loss. So if the loss is coming as a surprise, and then excessive dependency, or compulsive caregiving for the person who's lost. So often in a husband and wife who one person was always the emotional rock, and that's the person, and the other person was always kind of physically taking care of them, and defined their identity as the caretaker. When that emotional rock passes away, and that other person doesn't have anybody to take care of anymore, that can be a risk factor for having prolonged grief disorder. One thing that I'll just name is it's not been, humanitarian settings have not been studied much as far as like what does prolonged grief look like in a humanitarian setting, and what are possible risk factors. I would argue that like living through socio-political instability and war and genocide, those in themselves may be risk factors for prolonged grief disorder. I just want to take a moment to also address that, grief and even prolonged grief disorder are different from depression and anxiety, that have more defined treatments with medications and therapy, because these are grief is directly tied to a loss, whereas depression and anxiety may not be. Just being aware of time. So in humanitarian settings particularly, I think asking the person, like assessing if you're worried about, if you're seeing that somebody may be grieving, asking how the current situation, the disaster or conflict has affected them. Because again, going back to grief being, mourning of any loss, not just death and dying, a person who's living through a war or genocide is almost certainly grieving some loss. It could be loss of their job, loss of their community, loss of their house, loss of their status, or it may be loss of family or friends during the conflict. And asking, how has the loss affected you? Who is in your community of support? Are there people you can turn to? And so as a first step, just asking, and sometimes I think we worry about asking and what the response may be, and if we're going to make somebody feel worse by talking about the loss they're experiencing. And we know that generally people actually find a relief in being able to talk about what they're experiencing. I'm going to skip over this just in the interest of time, but it's basically a brief questionnaire that is used to screen whether somebody may have complicated grief or that prolonged grief. And the questions are essentially asking, like, how intense how much trouble are you having accepting the death of your loved one? Does it still interfere with your life? And are there things that you used to do that you no longer can do because you're still grieving very intensely? Some basic management, I think, essentially showing folks that they are not alone. Despite the grief that they may be experiencing, there are other people around them. As a first step, I think our role can be often just empathetic listening, just being there and listening to people and their experience, asking about their needs or concerns, and helping with basic needs and access services and social support to the degree that is available, and recognizing that in many settings it may not be. And then counseling about grief, which it can look different for different people, but you can talk about that difference, saying people may react in different ways after having a major loss, and some people may show strong emotion and others may not, and both of those are okay. And crying doesn't mean you're weak. You can allow yourself to cry, but then other people may also not cry and still experience that emotional pain just as deeply. Just they have other ways of expressing it. So normalizing different ways of processing their loss. Validating emotions, of saying it is common to feel the way that you're feeling, of recognizing that their experience is unique to them, that I can't imagine what you may be going through, and giving anticipatory guidance of how process of grief may go, that sometimes you may think that the pain you're feeling will never go away, but in most cases, the feelings do get less with time. And they become less intense over time. And then just encouraging self-compassion, that there's no right or wrong way to feel grief. And sometimes you may get reminded of your loved one and you may feel very sad, and other times you can enjoy yourself and just allow yourself to be, don't criticize yourself. I'm going to skip over this part too. And then importantly, to discuss and support culturally appropriate adjustment and mourning processes. Sorry, this is a very intense photo, but of folks in Gaza praying, doing the ritual of praying over the bodies of the dead. I think mourning ceremonies and rituals are so important and can be in order for somebody to process their grief, and also at some times to have closure about their loss. And when that gets disrupted, it can really affect the grieving process. And in humanitarian settings, because of the instability and because, that process can often be disrupted. Burials may not happen as they would have normally. And then I'm going to skip over some of this. Sorry, I'm at 24 minutes. I think maybe just to round out that when there's no right or wrong way to grieve, there's no one way to grieve, and that grief does not go on a predictable path, but it can just morph and change over time. And our job is not to fix grief, but instead to just walk with people through their grief, to lend a listening ear, and identify when more help may be needed. And to end with some poetry. So your body is away from me, but there's a window open from my heart to yours. From this window, like the moon, I keep sending news secretly. So even when we are not with that loved one, being able to still keep some connection. And so today we've reviewed how to define grief, bereavement, and loss, identify what it can look like and what prolonged bereavement or complicated grief may look like and how they're different, and then ask questions to identify loss in humanitarian settings, and learned how to, as an introduction, just to accompany and hold space for a grieving person. Sorry that I went over time. I'm going to stop my share and would love to, or actually, Erin, tell me, should I stop my share for discussion, or what would be most
Yeah,
helpful?
I can add in the references. We usually share a PDF after with everyone, but I can include those links in the chat for people who want to click on them right away. Thank you.
Fantastic.
Thank you so much for setting the stage for the discussion. One of the things we really enjoy about Project ECHO and this model of teaching is that we give quite a bit of time for discussion now. So I am really curious to hear our colleagues' thoughts on grief and loss in humanitarian settings. I know Sydney, one of our colleagues in Kenya, had shared that he's working with Hope for Cancer Kids, and he's a survivor himself, had lost both of his parents within a really short period of time, so 3 years, and just had said it would be really useful to use the questionnaire and identify some of the coping mechanisms dealing with this amount of loss in his life. Curious if anyone has any particular questions for Dr. Hedieh, or I'm happy to also put out some questions I have been thinking of, but you're welcome to raise your hand or you can unmute. We're a small enough group.
I think from my end, it's just interesting to note that grief can be so different for so many different people. People in the same family will lose someone and they'll all grieve completely differently. They'll all have their own time frame. they'll all be going through their own, a different phase of grief, if you could put it that way. So it's always, good to just try and recognize where's this person at, what stage are they in, and what's the best way to approach them. Because, telling someone it's going to be okay, or I know what you feel like, and, can bring back some of those feelings, and, someone can get angry. So it's always interesting to just kind of figure out where's this person and what kind of support do they need, or even sometimes just ask the person, how can I help, as opposed to trying to tell them, other things. Yeah, that's all from me.
Thanks, Sydney. Sydney has been working in the area of cancer care for many years here in Kenya. And I think it's a really good point, Sydney. As we care for families, we could be dealing with a sibling, we could be dealing with a parent, we could be dealing with a grandparent, all of who's in the same family, and how we react and support one person can be very different than the way we do that with others. And I think this type of work is not for the faint of heart. I think this is the one thing that is so important about palliative care, is actually it's quite individualized care. So you see the need, again, you ask, like you were saying, how can I help? What can I do? Dr. Hedieh, any thoughts on how grief can be so different? It probably at times can feel very overwhelming for frontline providers to support people. If, again, it feels like kind of complex.
Yeah, no, absolutely. And I think, Sydney, what you said about, I think how saying, giving advice, often people and including frontline providers don't want to sit in that discomfort of somebody experiencing intense emotional distress and grieving. And so they may, and we've all seen it probably, of people saying, wanting to move it along, or wanting to say something positive of, that's consoling that person. But sometimes that's actually not helpful. Like, the person needs to experience what they're experiencing. And so asking, like, what is it? How can I help? What would be helpful to you right now makes a lot of sense. And I think the other thing is when grief is showing up not as sadness, but as anger, and a person who is showing their anger and behavior, having angry behavior in the hospital or healthcare setting, that can often cause a lot of discomfort for frontline providers, and especially when they or people around them aren't able to identify it as grief, and are just saying, this family member is just so angry. And maybe the first step is to say, they're grieving. And that first brings understanding to all of us that they're suffering, they're experiencing grief, and then helps maybe to frame that for them too, and say, are you grieving? Are you experiencing, are you just already going through this? And how can we help you? You're on mute, Erin.
Oh, sorry. Rose, I saw your hand was up. Do you have a comment or a question? If not, there's a few interesting questions in the chat. Vilma, do you want to go ahead? Then we'll go to the questions in the chat.
Yes, can you hear me?
Yeah.
Yes, okay, sorry, I was just trying to get everybody out to school. Yeah, so thank you. I just want to say that I love the presentation and I love the approach. So thank you so much for sharing that. And I just wanted to add that one way of seeing grief that I find helps people understand how, people who haven't experienced any loss, that grief is, we grieve because we lost something that we love, right? So it's the price of love. And when we see it that way, really there's no timeline, because we're not going to stop loving the person. So if someone's child died, there's no time frame for, to stop loving them. It can be 3 months, 6 months, 1 year, 10 years, whatever. And we're still gonna miss them and love them, but that doesn't mean that we are not able to live our lives, right? It's just that the grief is there, and it's always gonna be, because we're always gonna miss and love that person. Yeah. Thanks.
Yeah, really interesting, Vilma. Kind of goes to some interesting thoughts from Elizabeth in the chat. And I think, again, this is not easy work, again, to continually support families that have experienced a serious loss and continue to allow them to experience that can oftentimes is not easy. And Elizabeth here in the chat shared that sometimes she's worried or concerned about her colleagues who say, don't worry, you'll have another child soon since you're young. Or why are you questioning God? This often stigmatizes grief. And I think this sometimes is a situation we find ourselves in. And it can be really hard to know how to work alongside our colleagues when they respond that way. Dr. Hedieh, any thoughts on that?
Yes, I also see that in colleagues and others, and I think the approach in order to like keep relationships and like teach others of what is helpful and what's not helpful is sometimes I try to just like role model of if I'm in that situation, like what do I say instead of that so that people at least hear a different response than what they are saying, right? Of saying, instead of saying you'll have another child since you're young, saying like like Dr. Vilma said, you're going to this is part of your love for your child that you've now lost, and it's a beautiful thing, and I'm sorry that it's so painful right now. You will learn how to continue living around this pain. And that way, that other healthcare workers are hearing statements that are not but the only thing they are familiar with, if that makes sense.
One thing I find when we respond to grief or we respond to loss as palliative care providers, and most of the people in our group have done some sort of introduction to palliative care, and they may be the only person in their setting that has had access to that sort of training. And I think, as you've just said, being the person that kind of takes that first step and begins to change the narrative of how we talk about loss and grief, for sure, 100%, we are going to make mistakes. We are also going to say something because we just can't think of the word that we heard Vilma or Dr. Hedieh say during a session, or you're just overcome with emotions yourself, and you'll go back to a kind of a very different response, which you had tried to kind of change some of your responses. That's okay. That is totally 100% going to happen. But as you think about, as you catch your kind of tongue in those moments and begin saying it, your colleagues will witness how you talk differently to your patients. And hopefully through that, they will see the response that families get from the way that you talk and the way that you care differently for them. And is one of the reasons we all gather here regularly. Please let us know. It's no shame in, oh my goodness, I had the worst situation. This is exactly what happened. What could I have said? Those kind of things are what we're here for. We're here to kind of support you, knowing that, and empower you in the work that you're doing. Sarah, I see your hand is up, and then we do need to shift over to our case. I see Annalice is with us also. Go ahead, Sarah.
Yeah, sorry, just on the theme of this sort of, I think it was Elizabeth who sort of got us thinking about this. But I think as healthcare providers too, the way that we're trained and the way that we're educated is to alleviate suffering, alleviate pain. And so in these moments where someone is grieving loss, the first thing we want to do is figure out a way to immediately help that person, remove that person from the pain and suffering that they're feeling. And it's this sort of what we've been taught to do, and our natural instinct to do that And I think, as Dr. Hedieh has been sharing with us, in these moments of grief and loss, it's counterintuitive sometimes, but it means that we're asked to actually just allow for that pain and that suffering to exist as we support the person who's going through it, and as we sort of are present and we're able to sit with them through those moments, which is not that quick-paced kind of action that we're used to sort of employing in stressful and critical situations. So it asks us to respond differently. And I think it's something that we all can learn with practice, but it takes time for sure.
Thanks, Sarah. It is actually kind of unique. As you were speaking, I was thinking of how a lot of what we do teach in palliative care is to find ways to alleviate suffering. And yet we sit in this balance, right? Where we know it's natural, this is happening, people are losing people they love. And it's this balance of alleviating suffering while sitting with our patients and engaging with them, and not only our patients, but our families, who then kind of become our primary focus after their loved one dies. Maybe we'll come back to this, Sarah. I think you'll be one of our guest speakers at some point. I think you do actually have a teaching session coming up. Anyways, okay, so let's go on. Dr. Hedieh, I don't know when you have to go, but there are some comments in the chat. Would love to, I see you've talked a little bit about anticipatory grief. There's also one there about support systems for grieving families.
Yeah, I'm happy to
So
look through and just
yeah,
comment.
perfect. Okay, so we'll now shift over to our case discussion. So we wanted to introduce our team member that's going to be presenting the case for today. You all know her very well. Her name is Annalice. She's a senior nurse with palliative care training, currently working at International Rescue Committee in Dadaab refugee camp. And I guess I would call her a palliative care nurse. Although it's probably not what is on her contract. She is known at IRC to support all the palliative care patients, and she does her work so well. She's also one of our faculty members and often comes forward to share cases. She is very busy, so she's been getting some extra training herself, but I am so grateful that she made time for us this week. So over to you, Annalice. Let me know if you can see my screen, and I'll just put it into slideshow form. Annalice, are you okay? Can you hear us? Sometimes the connection is...
Hi, I'm okay.
Karibu sana.
Thank you. Welcome all. My name is Annalice, as you heard. I'm sharing a case on grief and bereavement, as we have Harriet has explained to us. So the subject is we have to put in mind the questions that are stationed above, that who should blame for these pains, and how best could we have supported the family? Could a referral benefited the beneficiaries? Who else could we involve in the current team in such a case? Okay. The case is of a 38-year female who was diagnosed with a IO in multiple pregnancy. That was on 3rd of January 2024. The NADA diagnosis later came with the severe anemia and the APH, that is antepartum hemorrhage at term in multiple pregnancy. So the treatment and investigations done were the lab works was the full hemogram. Then there was the urea, creatinine, electrolyte, and creatinines. And then the liver function test, the stool and urine microscopy. X-rays were obstetric scanning, abdominal ultrasound, and then abdominal X-ray. The OP scan done on October 20 revealed multiple pregnant features in normal growth status, which was expected. Date of delivery was to be on 20th of January. And then on 3rd of January, patient was admitted with severe vomiting and diarrhea, alternate with long days of constipation. Then abdominal scan revealed partial intestinal obstruction. Treatment given but declined admission on that very day. Then we went home again, came back on 5th of the same month, admitted with vaginal bleeding, and she was in 2nd stage of labor. Declined cesarean section, but fortunate enough, she progressed and had a safe delivery to 2 baby girls, but they were not living. They had already passed because of the bleeding before. Then the first encounter when assessing holistic pain and symptoms was included on 3rd of January. The patient was with mild pain and managed with paracetamol along relevant microbials and antibiotics indicated in pregnancy. On 5th, the patient was in severe mixed child labor and general abdominal pain. Intravenous paracetamol along with other emergency medicines in labor and bleeding given. After delivery to selected children was in severe mixed pain. Total pain clear now with where multidisciplinary care was involved. Mental health care, the spiritual leaders, nutrition, community health program or reproductive health. The theater was involved because she was to go for cesarean section. There was combined medical team as she was bleeding. Patient was for urgent referral to Garissa for obstetrician and gyne review and other surgeon management. It was fortunate enough that the patient was managed to, referral was managed, but the patient came back again. And when she came now, she was having a colostomy on. All along, she was being taken care of by her elder son, who is 20 years. So the mother of 10, ages 20 up to 1.5 years, the young one, with the husband, he has a non-controlled diabetic. Then she's a visiting refugee from Yemen. She loses twins, 2 children. Then separation from the family during referral. Then there was the effects of living with the stomach. All these were psychosocial concern for the patient and the family. And healthcare workers. Then, so the family's concerns were who will take care of the kids while she was away. Then why they had to go through all what they went through, and then where and how they will manage care of the stomach. There was worry. Will she be able to resume her normal duties of a mother? All these questions were raised by the child, the children, and the husband and the brothers. But we could not give them the correct answer. So in communication was fairly done with the consideration of understanding level, both from the antenatal through referral to and from Garissa. Then multidisciplinary care was practiced, especially when she lost her babies and was to be referred to major operation away from her kids and the other family members. But as usual, our setting does not provide the privacy, since only normal screens, the one for cloth, the one we screen with, can be used to separate the patient, but the sound will still be heard by everyone else around. Then tried nursing her at the isolation room where she could, when she had returned with the stomach, but because of the relatives now want to visit her, everyone want to see her, again becomes a congestion to the small room. So we had again to remove her and put her in the general ward. Then there was a family conference only involved the brother, the son, and the husband, minus herself, because she could not walk from her bedside. So we only talked to them and counseled them about what was happening. But again, our culture in our community, our culture does not allow people to grieve for long or to cry. So even when she lost the children, she could not cry, she could not do anything, and she was also not in her normal status. The patient and loved ones believed that God was gives and God takes. That is in the spiritual concern. And if he permits this to happen to them, he alone can resolve their pain and sorrows. And they were hopeful that their loved one will be healed and continue caring for them. But after her final rest on 20th of April, they will hold their anger, blamed everyone for not assisting them enough, but grateful to God for relief and the palliative care team for being there for her management. The Sheikh never failed to visit and pray with and for them. They always come and pray, read for them the word of God, which at least he could bring relief to her for some times. The multidisciplinary team, that is the holistic current collaboration and partnership in care. There was a multidisciplinary team at the institution level, then the UNHCR during referral, and the Kenya Red Cross in the referrals, the government officer for refugees in Dadaab. Then the community health leaders also were very supportive. The MCH and family planning staffs and the clinical service team. Because every time they came to visit her and review her, they could change her medication, they could send for lab works, and the shares and other family members. And the Garissa County Teaching and Referral Hospital team who operated on her and they successfully made the stoma. She was supposed to go back for referral on the 36th of May, but she couldn't because she passed on 20th of April. A special thanks to a friend who provided quality colostrum bags that sustained her all through, and even during her demise, she left some which somebody else has benefited from. So in summary, this is a 38 years female para 10 gravida 11, diagnosed with the IAO in twin pregnancy, admitted first and at second stage of labor in severe mixed pain and bleeding that caused severe anemia to transfusion and loss of the babies, was referred and operation resulted to a stoma. Then after 3 months of intense pain and suffering, she succumbs in depression, leaving behind an uncontrolled diabetic husband and young kids. Communication was fairly managed to the setting and the available resources. So who should be blamed for these pains? And how best could we have supported the family? Then could a referral benefited the beneficiaries? Who else could we have involved in the current team in such a case?
Well, thank you, Annalice, for sharing this case with everyone. I have a few questions for you, and then I think we'll bring the questions to the group. So Annalice, did they ever identify what the initial cause of the intestinal obstruction was? Was it the pregnancy that caused the obstruction, or was there another underlying diagnosis?
Oh, no, it was just the pregnancy.
Pregnancy. Okay.
Yeah.
And then, so she was referred to Garissa, and then she, when her daughter or the twins were born, they died shortly after labor, or being born.
No, she gave birth to dead babies before she was referred to Garissa now.
Okay, okay. So she was, during the time before she was referred, she was already experiencing traumatic grief because she lost the babies that she had been pregnant with.
Yeah,
Yeah.
she had lost the baby and she was in pain.
Mm-hmm. And then was there a plan for them to reverse the stoma that they had done once she kind of recovered from the blood loss?
Yeah, there was a plan that she will go back on the 6th of May for review and then further management.
Yeah. And then where did she actually die? Was she still an inpatient, or did she die at home? You said that she had depression. What happened?
Yeah, she was discharged, went home, and then after 1 week, they called me and I advised them to bring her back to hospital. When she came, she was already into depression. She was not eating.
Yeah.
So we had to fix an NG tube to feed her. She stayed in the ward for a few days, and then she could, after the psychosocial support from the mental health team, talk to her, she accepted to feed. Again, after 2 weeks, again, she went back into depression.
Yeah.
And then we again refixed the NG tube. So by the time she succumbed, she was feeding via NG tube.
Okay, pretty complex case. Again, every time you bring cases to us, we're really grateful for this time of discussion. So we'll give it to the faculty who are on the call now. If you have any further questions for clarification, and then I'll put the questions that Annalice brought to the team on the chat so you're familiar with what they are. But Annalice and her team are curious to know, in situations like this, when there's extreme pain, who can be blamed, or how do we process this pain? How best could they have supported a family going through such severe loss? Would re-referral have benefited the patient? And then who else could we involve on this team? So I see Sarah's still in the call. Dr. Hedieh, if you have any initial thoughts and you're available.
Hello. Hello, team.
Hi, Bull. Nice to see you.
Nice to see you again. It's been a long time.
Yeah, a long time.
I've been off network for so long, and I'm very happy to be here now in session 8. Yeah, sorry, the case, I just got the last episode of the case about where the patient died.
Yeah.
I was going to ask my colleague Annalice about what was found out to be the cause of the intestinal obstruction in pregnancy. That was my first question. Then maybe we will go later in answering the former question that were shown on the screen. So what was the cause of the intestinal obstruction in pregnancy?
Actually, we couldn't figure out what it was, but when they were doing operation, you were told that there was just some adhesions of the intestine to the walls of the uterus. So we couldn't figure out.
Okay, and finally, the patient passed away. Did the child survive? Were they twin or single? And did they survive or they also passed away?
She gave birth to normally vagina, but the children died. They were twins, eh? They died.
All right. Actually, it was actually a terrible condition. If I could be the one managing the case. Yeah. Here, actually, we can go into psychological support. We can talk to the family about the incident that has happened. And as in this, we relate it to God. Since everybody has a belief in God, whenever He says the thing happened, and no one among us knows how it happens, it's only God who knows it. So the best thing is to put in prayers and leave it like as it is gone. I think it's the best way we can talk, or we can break the bad news to the family about what has happened. Since everybody is aware of the death and how people died when they are in difficult situations like that, and also breaking them the bad news about what killed the patient, I think they can be much more relieved other than leaving them without knowing what has happened to the patient. I think this is the first thing that I can do, together with the help of the counselor.
I think we just lost Bull. Maybe the connection was also not great. Bull is a provider practitioner in South Sudan. So sometimes their connection is not so good. Dr. Hedieh, do you want to go next, or Sarah? Yeah.
I just wanted to say, I think, first off, just like how, like what a distressing, complicated situation. And when I guess that like concept of total pain that this person was experiencing, there is the physical pain, there's the pain, the emotional pain of acute grief. There is also the like pain of and the grief of losing a lot of ability, right? Of now having to live with the stoma and not having maybe ability to take care of the family. And then there's the like bigger social pain of refugeehood. And I think that question of like who should be blamed for these pains, my first thought is like what are the pains, and then what has caused the pains. And some of it is like the bigger systems should be blamed for the pains, right? Of what caused her to become a refugee. And then, and so not necessarily just saying, oh, some of these pains are things that maybe none of us can fully alleviate. And we can, to the best of our abilities, provide counseling, provide, medications for the physical elements of pain and spiritual support that they're receiving. But sometimes the pain, despite all of our best efforts, it's beyond our ability to care for and alleviate completely. That's just my first thoughts.
Sarah, do you have any thoughts that you want to share? And then we'll allow others from the group.
Thanks for sharing, Annalice. That is really, really difficult case, and obviously really must have been a huge challenge for your team. I don't know how many comments I have. I think it sounds like you guys did a lot of things really, really well, trying to get her referred to Garissa and getting surgery for her and everything like that, given like the access to resources that you have. In a case like this, where it sounds like there are so many unknowns, there isn't really a clear understanding of what caused the intestinal obstruction, not necessarily a clear understanding of what caused her death in the end. That adds another layer to like the grief of the family, and even maybe for the patient here who experienced the loss, just not really understanding what could have caused all of this. So it's a difficult thing to add to grief when we have a lot of unknowns involved. And I think in your situation and many people's situations of work right now, there are often so many unknowns because you can't explore diagnoses all the way, or you're limited by different tools and resources. And so people are left to not know really what could have caused this. And I'm not really sure, I guess, what the answer to that is, but that would, in my mind, would add another level of challenge to dealing with loss, and to dealing, and also to accepting a loss, and to moving forward without really knowing what happened and what caused it. So for this family moving forward, I'm sure there are so many challenges for them, without really having a full understanding of how all of this came to be. I'm not sure if anybody has experiences like that from other settings where they've navigated that with family members that they would want to share, because I think it comes up a lot here, just a lot of unknowns that people are facing, and then the losses that come from that. But yeah, I think you guys, well done to your team for everything you did in this situation.
Thanks, Sarah.
Annalice, I know that from our work in Kenya, some of the NGOs do have more resources related to mental health support. I'm sure it makes sense to refer all of your patients for extra mental health support, but I do wonder if there's a way, if you don't have enough resources, you could potentially connect with MSF. I know the MSF team had some highly trained mental health providers. I would say this husband is at very high risk of going into also major depression based on the loss that he's experienced, not only of his children, but his wife. So I would say if there's urgency in this situation, oftentimes in healthcare, we think of the person who's alive and the urgency that comes with that. So in this situation, now that the patient has died, maybe we feel there's not as much urgency. But if there's a way for you, and I know it's often related, you have many, many patients and families to deal with, but if there's ways for you to refer the husband and potentially some of the older children that could process with a mental health provider what has happened. I would say, if it's possible for you to do that, maybe that's something that your team could offer. I did hear during the case that you had shared that you guys tried to offer her some kind of private space to grieve. And I do want to highlight how important that is. And I know that you said in our culture, we often don't allow people to cry. Just by you thinking of where is a place that she could be kind of private by herself to grieve, I think shows that your team is really growing and really maturing. Although it sounded like it was kind of short because then all the family came to visit and then there was no space for anyone to be in that kind of private room. I do really want to acknowledge just that thought of your team and the action that you did. And I do hope that there will be like fruit from that action, that your colleagues have seen that you prioritize that people should have a space to be able to cry and mourn and grieve the loss that they've had. Will you be
Thank you, Erin.
interacting with the family again in the future? Do you, I know you had messaged me privately saying that you were going to try and visit them. I know that's probably beyond your job description, Annalice, but you're amazing. But do you have a plan to meet with the family officially with IRC?
Yeah, you have a plan with the Ali
Okay,
and the other team.
yeah. Okay. We're getting close to our time. Does anyone else have a comment for Annalice and her team? There was a few other questions. How could we support the family? Is there anyone else that they should have involved? I know we have some other senior palliative care providers on the call. Pamela is with us. Rose from Uganda, Rwanda. I don't know if you have any final thoughts to share with Annalice and her team.
Thank you very much, Erin. I can just say that some of these cases are so complex that even you wonder how to manage them.
Yeah.
But the approach is that we just need to deal with them as they come and just find a way of having a multidisciplinary approach whereby we can get how to support one another, like the meetings that we are having now. I listen to them and I've just started doing my work in the humanitarian
Yeah.
area. Julie's in Okba and Amoni OCA, and it's so challenging. Even today, we're having a very challenging case from Mugul in Somalia, and it's an area that sometimes you ask yourself, how are people managing? But also those people, they need us, that we really have to come up with a strategy whereby we have to support them, we have to reassure them, and we don't have to say that nothing can be done. We can say that whatever we are doing, it's we will support you to the end. We will give you the necessary support we are able to do. We may not be able to modify the condition, but we are able to make you be with it as comfortable as possible to the end of life. So it's a really challenging area. And I really appreciate the work you guys like Annalice are doing. I really need to get in touch with you people so that I also get a lot of experience in this. Yeah, thank you.
Well, I'm sure the team, Annalice, Rose, give me 1 second. I'm sure the team, Pamela would be willing, the team in Dadaab would be willing to host you. So you should make sure you connect with her.
Yeah, I should get there as well. Yeah, thank you.
Yeah, welcome, Rose. Just one more comment.
Welcome.
Yeah. Thank you very much. I think, as the former has spoken, it's a really difficult situation sometimes. I think you have to look at what do you want. There are some who feel that, as someone said, you go with them, you advise them, or you guide them according to what they feel themselves. You don't give them the answers, but you support them on what they are thinking of doing. For example, if they want to have like a sheikh, and the sheikh is not available, then you look for the sheikh and say, this is the sheikh, and then you support them in whatever condition they are in. You show them sympathy, you show them that you are with them, you show them that, but you don't really dictate them what to do, but you move with them what to do. Because sometimes the grief can take long depending on the relationship or the attachment of that person who has died. And again, the grief also can take time depending on how that person who have died, in what situation that person has died. Because I think wherever we are, we shouldn't die in pain, whether we are in a country or outside our country. So I didn't hear about the morphine when that lady was in much pain. I don't know what they gave her to reduce her pain, but of course she had pain before, and of course she had a lot of pain, physical pain, psychological pain, and even losing her twins and everything. She has a lot before she died, and that also affected the family. You can see the brothers and uncles were the one who were having a conference. But she had gone even in depression before even she died. So I think we have to move with them, show them sympathy, and we say, and of course we help them whatever we can, but we don't tell them the solution. They look for the solution themselves. Thank you.
Annalice, just a quick question. Do you have, are there services or are there any specific resources available to you and your team specifically for loss in pregnancy? Do you have specific anything like that available to your team? Because it is such a unique type of loss.
No, we don't have resources as such, but when a mother loses a child or children, after the treatment session in the maternity ward, or whether they are at home, they are normally just left to go on their own. So very few will find that the community health care workers will follow them up at their home level. But there is no proper system that we follow them from the clinical point of view. This was just a special case. That's why we managed to follow her up until she had.
I don't know if we lost Annalice. Can you hear her? Maybe.
Yeah, no, thanks, Annalice. So that's really interesting, and that it might be helpful for your team to get a hold onto some resources specific to loss in pregnancy. Maybe Erin and I can talk about that a little bit and maybe we can chat afterwards, Annalice, or something, because yeah, that would be probably maybe that would be beneficial to you, but yeah.
I have a feeling, although I haven't been to Annalise's, like we've obviously worked with her for quite some time. I have a feeling in this situation, the team probably reached out to Annalise's team as the resource. But then obviously if it's not something that, yeah, obviously I'm sure your team did do really well, yet you may have felt that your hands were a little bit tied or you didn't know exactly how to respond to everything. So we can definitely bring that. I was also thinking that through this case, we can definitely refer people to sheikhs and religious leaders and community health workers, yet if they have limited knowledge of how to talk about grief, for example, what Dr. Hedieh was saying, it is sometimes it's a very good resource because it's a localized resource. Maybe people are familiar, yet sometimes we can also empower those groups to do palliative care approaches in how they support people going through grief. So I wonder, Annalice, over the next little bit, we could also potentially look at if there's some people that seem to be receptive, inviting them to some of our sessions, so they can become sensitized to understanding that grief is not an illness. Again, all these things we kind of talked about today. But we're definitely going over time. So I am going to end our session there for today. Thank you, everyone. Thank you, Annalice. Thank you, Dr. Hedieh, for your involvement on the call. We meet once a month. So if you are interested in joining again, it will be the same time, the second Tuesday of the month in June, and really looking forward to having you. We do need a few more people to sign up for cases. I can't always call on Annalice, but obviously we're grateful, Annalice, when you bring your cases forward. But if there's others in the group that would like to share a case, Sarah and I and a few other faculty can help you kind of prepare and get ready for that presentation. So thanks so much, everyone. We'll see you next time.
Thank you. Bye.